Sawadee Krap. Good morning from Thailand. My name is Zin. So today I will be the MC for the day 6 of the virtual training for ending HIV stigma and discrimination. So today's section will be Module 7, War Café Stigma and Discrimination Package, and Module 9, what country need to know or how to implement 3x4 package or S&D reduction in health facility. So before we start Module 7 and Module 9, I would like to invite P. Niwat to start with the rubber session for the previous section. So I will give floor to P. Niwat, please.
Okay, thank you, Dr. Sin. May I say good morning to everyone? If you hear me, can you send some things like your symbol, wave your hand, knock your head, or even give us yes, Dr. Yes, or, yeah, some give a heart to me. Okay, thank you. I do hope that everyone are doing fine, right? Okay, yes, Miss Robin. Okay, thank you. Okay. Since we have a long weekend, right? And this is our last week for the 2 sessions. And we need more time to do lots of things too. So I think I don't have anything to wrap it up. It's quite have a lot of story, but today we invite a lot of resort person to come and share with you. So I think I will start it earlier. Like Dr. Sim mentioned that today we have 2 modules for today. Module 7 is, we call it Work Cafe. Work Cafe, it means we kindly think that there's some other things that we have developed and kindly linkages with our 3x4 packages program. It's not an additional program, but it's a kind of special program that might help kindly broadly experience of working on stigma and discrimination. So from the first, we start with the healthcare facilities, but later on we extended to cover on the key population-led service. I'm not sure whether other countries have this kind of model or not, but I think Mr. Thirdchai will briefly tell you what is key population-led service and what we are doing on stigma and discrimination related to HIV and key population in key population-led health services. And the other program is doing around self-stigma reduction program that I think it's needed to, when we also working on reduction on healthcare worker site, and we also do need an effort to work to help create self-esteem on the client or the customer side too. And the latest one will be a key crisis response system that is help to fulfill pictures of the stigma and discrimination reduction in terms of right protection. So I think this is all around for the module 7 for today, and module 9 will be ready for you. Our intent to do module 9 is try to help you walk through when you try to draft your idea of working on kind of action plan to initiate or even strengthen your stigma and discrimination reduction program in your country. So before tomorrow that you will have a chance to tell us what is your idea, initiation or strengthening or expanding the stigma reduction, the stigma and discrimination reduction program in your country. So today is a chance to meet with the other experts. And if you have any questions that you need for clarification, or you need to know anything more before planning for your own, you have a chance to talk and discuss with the experts. So this is all around for today, and we still have the last announcement before tomorrow too. So I heard that today some of you informed me that you may have to leave. Some of you may have to leave earlier because of an urgent task to meet with the high-ranking officer in your country. That is fine. Leave at your convenience. And the other also have kind of health problems, and recovery right now. So I do hope that everyone stay healthy and stay safe. Okay, so we better start with the session today with module 7 because our 3 speaker was already in the room. So I think I'll go back to Dr. Sin to a kindly brief introduction of our first speaker. Please, Dr. Sin.
Thank you, Piniwat, for your wrap-up and also a brief introduction or today courses, today module. So we will start with the module 7, World Coffee Stigma and Discrimination Package. So first of all, I think I would like to invite Ms. Daruni to introduce about the module, I think. So we will go to the first speaker directly. Okay. Sorry for my misunderstanding. So this section will be divided into 3. There will be 3 speakers who will share their experience. So first is Mr. Thirdchai, second will be Dr. Sunisa, and third will be Ms. Siriporn. So for the first session, I would like to invite Mr. Thirdchai, who is the Senior Technical Officer, Key Population EP Project Thailand from FHI 360. So Mr. Thirdchai, I will give floor to you. Please, you can start the section.
Good morning, good afternoon, and good evening to anyone. Okay. Today is very pleasure to be here to introduce our anti-stigma and discrimination in KPLHS services. Before we go into the detail of our intervention, I would like to give a brief introduction on what is the key population-led health services or KPLHS in Bangkok, Thailand. Okay. The KPLHS or Key Population-Led Health Services is another community health center that developed under the USAID Linkage project. It's the previous project before the EPIC project start. That's first launched in Thailand. The KPLHS was led by the KP community leader to provide the service necessary for addressing the HIV epidemic and related health issues that are identified by the community itself and are therefore need-based, demand-driven, and client-centered. Empower the lay provider to be equipped with the knowledge to correctly and adequately to giving the HIV counseling and testing, the STI testing, and also PrEP and PEP dispensing. And now we also expand the service in the KPLHS to be the TB screening, STI sampling for just like syphilis. We have the point of care for test the CD4 and also the hepatitis B. You can see that our KPLHS expand the role that our community-based staff can do from the conventional one of only the distributing the educational brochure, condom, and lubricant. And yeah, sometimes we are waiting for the nurse and lab team from the hospital, right? If they are available to accompany them to do the mobile testing, this is only the role. And now we are expanding to do the KP lay provider that can provide the high quality of HIV testing and dispensing PrEP and PEP. This is a model that we developed, is the framework, that we developed the service under the KPLHS. We call the RRTTPR cascade or HIV cascade. If you see, firstly, in the traditional organization is only do this for the CBO, reach, recruit, and send to the hospital, and then do the retention care and support staff after get the ARV at the hospital. And now for the KPLHS, we can provide all the service just like reach, recruit, test, treat, prevent, and retain all the client into the services. The key characteristic of the KPLHS model which contribute to its success include the factor related to the accessibility, because that the location of the center are located in the hotspot with flexible service hour, providing one-stop service, and have availability of the service beyond the HIV, such as the hormone service for the trans women, legal consultation for sex work. The second is the acceptability, because the staff speak the same language and the clinic environmental set as the stigma and discrimination free. And the lastly is the quality, which is the assured and accepted by the local public health facility. Okay, we go to the next question that were rising, that why we need to focus the S&D in the KPLHS unless we have the KP lay provider working and all the service and the environmental that we built under the KPLHS is claim that the S&D free. When we develop the KPLHS, many staff transition from the prevention side into the clinical services and can still provide the care with no stigma and discrimination while upholding human rights standards to increase the accessibility to health services among MSM and TG. This is the reason that why we are develop the anti-stigma and discrimination intervention into the KPLHS. It's not just like the FHI 360 work only. We are working with the Foundation for AIDS Rights and the Right Hit from Chiang Mai University to develop the anti-stigma and discrimination curricula. And the package, we have the training package and survey also. This is the S&D conceptual framework, and I think that you may familiar with, because that is some kind, it's not some kind, it's similar to the national framework, because that we want to align with the national guideline. We can see that we have the key area of the intervention, development and measurement for both driver and manifestation. Just like that, if we can decrease or remove the domain, we will be able to reduce of the negative outcome and impact of HIV stigma. For actionable driver, this includes fear of HIV infection, negative attitude, and lack of proper law and policy. In this actionable driver, we are not examine the unaware driver, because that our service in the KPLHS are not leading to some kind of the more medical or clinical. It's just only the blood draw that we are doing at the service at the center. So we are not consider this driver. For the stigma manifestation, this includes the perceived stigma, the discrimination, and also the disclosure, the internalized stigma, and observed discriminatory and experience discriminatory. So this is the step of the implementing the S&D in KPLHS. It is quite similar to the national S&D intervention that you may learn from the previous section. First, we do the survey. We are conducting the survey for both client and staff. And then we are do the training with all the staff and discussion the result from the survey. Third, we will do the focus group discussion with the client to get more detail. And lastly, we are develop the COP based on the result of the survey and the SDG. For the survey, we are using the framework that I presented before to design the questionnaire based on the S&D framework. The questionnaire in the survey was laid out similar to the national S&D survey, except only unaware factor, and we adjust some questions to reflect our service. The baseline survey, we will collect it from all the clients who get the service in 1 month, and the analyzed survey will collect after 6 months from the training and COP. Okay, this is the questionnaire domain for the staff. We will divide it into 2 domains. In the dark blue is the stigma manifestation, and the light blue is the stigma making. You will see that for the light blue, we collect the fear of infection 2 items, negative attitude toward HIV and KP 4 and 5 items, the KPLHS policy 4 items. For the stigma manifestation, we will collect the overprotection 2 items, S&D observation toward PLHB 4 items, S&D observation toward KP 4 items, self-stigma 6 items, and the last one is the sexuality and KP status. As I mentioned that, the survey was collecting all staff, such as the management level, outreach, clinic, and also housekeeping as well. For the client, we collect 5 factors to understand what is the stigma and discrimination experience from the client. The time frame that I mentioned before is the 1 month for every client who receives either outreach or clinic services. We will collect discriminatory experience on from the HIV and KP 5 item, self-stigma 6 item, HIV and KP status confidential 4 and 3 item, discriminatory experience in family and community 3 item, HIV infection history 5 item, and KP status and sexuality. After we conduct the survey, we do the 2-day training that I mentioned. All staff are required to attend this training. The module is same with the national that I think that Piniwat was show you in the previous section, that we have 11 modules. The objective of the training is aimed to understand the concept of the S&D, reviewing their existing practice that may lead to stigma and discriminatory practice, and develop the course of practice and policy to prevent it. This is some agenda for the training. The first day, the staff will understand the form and driver of the S&D. The second day, we will identify the S&D occurrence in their own site, key principle of the S&D reduction. After the end of the training, participants will draft the code of practice to prevent or reduce the S&D for their own KPLHS, as well as develop the work plan and critical additional activity. The COP will be further used to develop and integrate the S&D element into our project SOP. For after we are done the training, both survey and training, we are randomly selected the client to do the focus group discussion. The objective is to collect the feeling and suggestion of the client who receives the service at the KPLHS and develop the anti-S&D policy, and open the opportunity for the client to share their experience about their S&D. In each site, it is around 20 to 30 clients mixed with MSM and TG population will be participated in the focus group discussion. The question that we use for SDG is to explore and learning the inside information on the S&D, and this is some the item that we are asking during the FDG, just like what is the service that they receive, why they come to get the service at KPLHS, what are the S&D experience in the KPLHS site that they face, and also if they have the experience on get the service at hospital, we also explore and the suggestion for improve the service at KPLHS, and last one is the self-stigma. This is some sample result of the intervention before and after we implemented. First, the negative attitude of the KPLHS staff toward PL-HIV and KT. The highest negative attitude was among the drug user and people living with HIV. And after we implemented, our negative attitude was reduced across KP type except the MSM. For client experience on discriminatory practice at each KPLHS, all the CBO improved except the CBOB. We try to find out more why the CBOB, the post-intervention is not effective. The result that may be explained that the CBOB, when we collect the line, they have some restructured organization based on the funding reduction, and many staff was laid off and changing their role. And I think that it is the one reason that will affect to the client experience on discriminatory. The example of the discriminatory practice that we collect, such as the impolite or unready of staff on providing services, waiting for a long time, impolite posture, conversation from staff, or maybe gossiping. The last one is the label of internalized stigma from the client. The data will show that all the KT have their high internal stigma and may become a barrier for the health-seeking behavior. But we do not have any intervention to reduce the self-stigma. The sample question is just like, it's hard to tell another people that you are MSM or you had yourself as being a trans woman. This is some sample question that we asked in the survey. I will show that some COP that we are asking the staff in KPLHS to draft it by themselves. First one is that the sole client folder in the locker cabinet before the clinic open. The second is the recap about the TB knowledge and preventive measurement to all the staff, because we found that our staff feel very concerned about the TB infection. Third is the adding S&D policy in KPLHS quality manual. Third one is we have the process to self-evaluate staff emotion and shifting the staff for rest during the high caseload. This is from the focus group discussion. Some clients are feeling that when we have many people are waiting in line for get the testing, some staff quite stressful, and it may reflect to the face, the gesture that is not polite or not ready to provide the service. In some organizations, they want to make the S&D as the highlight. They want to develop their own S&D policy. And the last one, they want to, they recommend to integrate the S&D into the normal training for the staff certification, because that firstly we are separate the training and the training for S&D and the staff certification training. This is the first part is we are focusing on the annual stigma and discrimination, but also we have another tool to ensuring the S&D are free at the KPLHS. I will give the brief detail that another tool that we are used in our project. We have the three. The first one is the Listaway. The second is the quality assurance and quality improvement. The last one is the mystery client. The another tool is not directly combating the S&D, but they have some part that we can help each other, just like synchronize the effort to reduce the S&D. First one is the Listaway Link. Is the new technology-based system to routine monitor client satisfaction with the HIV services. The objective of the Link survey was to reduce the stigma and discrimination in healthcare service, reduce the failed referral, increase overall client satisfaction and among the service user. The steps of the Link survey: after the client got the service, either outreach or the clinic service, they will ask to scan the QR code and they'll lead to, then you get the link to the online survey. In our program, we use the Survey Monkey as the host. The questionnaire will be displayed in the skip pattern. The client will answer only the service that they receive, follow with the open suggestion box as the optional. Client have a right to leave the comment with anonymous or give the contact detail if we would like to get any help or solve certain issue. The time for giving the survey is very short. It's around 1 minute because that we want to lose any valuable comment. The system will automatically generate a report on monthly basis and send to our colleague in FHI and the head of each organization to monitor the service. The report can be disaggregated by site and organization, and our staff in FHI will monitor the result, especially on the comment section. And if we found a negative feedback or the issue or the problem, we will respond as quick as we can. I want to give them one example that we found. We have one client report that in our Link survey that he is uncomfortable while getting the service because that they feel like our staff are pushed hard to get them to push hard on persuade them to get to provide the index testing service. And when we reading their comment in the Link survey, and they also gave the number, we contacted them, we called them immediately to asking for more detail, give them apologize and feedback back to our staff. From this case is because that we work proactively, so this problem are not replaced, and our client understand that why our staff are pushed so hard on the index testing, and this can prevent the post on the social media that will affect our service. This is some result from the Link survey in 2009 from Japan to Jan to December from 9 provinces. For the outreach activity, we have around 200 respondents. 69% is very happy with the service. For the clinic, the respondent is around 300, and also 68 is very happy. The suggestion that we've got is the first one is expand the service hour, expand another health services, fast service, and improve the service mind of the staff. Next, this one is not related much on the S&D, but also we have some part that talking on this. We call the quality assurance and quality improvement or the QA/QI activity. The objective is aim to monitor the quality of the staff and service in KPLHS site. The committee are from provincial level, is set up at the provincial level, and the representatives are come from provincial public health office, the local department of disease control, hospital, national health security, the Institute of the HIV Research and Innovation or HI and FHI. The QA/QI committee will use all the quality tools in our project, such as SIM, if in some country receives the funding from USAID, we must to comply to the site monitoring through site improvement through monitoring, and also program SOP and the national curricula. The QAQI will conduct in yearly basis and come up with the improvement plan that FHI and IHI as a technical partner will help strengthening and make them ready for the next round. This is some picture from the QAQI activity. This is the result during QAQI from the staff. Is about 60% that we evaluated both content and the skill of staff. Last one is the mystery client. Mystery client, we are developed to achieve the sustainable standard under our EPIC project. Our technical partner, IHI and we, has initiated the mystery client clinic service quality survey at the registration, counseling, care support, treatment, and laboratory. And also we include the online reach, the online intervention into the mystery client. The purpose of this activity, we want to observe the behavioral and attitude of the staff to make sure that they follow the SOP, to identify the strength and weakness of the community-based clinic and opportunity to improve the quality of the service. Assessment process. First, we are open the application to the all the PLHIV. We want the positive client to be act as the mystery client, because if we are recruiting the normal people, some service are not provided, because that if we are not positive, we cannot measure the care support services. So we recruit only the PLHIV. When we got the list from the mystery client, we will train them about what is the standard of practice of our program, and what is the minimum standard and item that they need to access. And then the MC observe the site and receive the service as a normal client. What is the observe? Is they observe on the attitude of the staff at the registration, at the pre and post counseling, blood testing, and also the online intervention. After the site visit, the mystery client will complete the checklist in the electronic form, and after that, our staff will call in to interview to get more detail. And after that, we develop the report and send back to the CBO. And after that, our program will delete the client profile of the mystery client to protect the confidentiality. This is some sample of the mystery client. They need to introduce themselves and providing their role. Sometimes they forget to do the TB screening. They need to forget to talking about the basic STI information, or forget to ask the UAC code before telling the HIV testing result. Safe sex and proper condom and lubricant not inclusive and positive result. This is some sample of the questionnaire result that we ask our mystery client to access. Just like the first part, this is the location. Yeah, we asked about what the clinic near to the public transit, the cleaning of the facility, the posters, something like that. And the second is the registration. We ask about the time, what are the time for the waiting area. Okay, this is the lesson learned that we got from our anti-S&D in KPLHS. First one, just I mentioned that just because an organization offering the health service led by KP member, does not mean that we are the truly KP friendly. It may be especially true when an organization goes from prevention especially only to clinical service. This is why we have the S&D intervention. The measurement of the stigma is vital to make sure that we are truly offering KP-friendly care. No? Third one is the while level of the stigma toward MSM are low, but when someone is positive or have another we call subpopulation, just like the drug user, the stigma level exponentially increase. The last one is that the internalized stigma may not be affected by changing in healthcare worker treatment and can require a separate intervention. Okay, thank you so much. And if you have the question, please. Thank you.
Thank you, Mr. Thirdchai, for your comprehensive presentations. Not just only introduction of the key population-led health service, but also providing in detail about stigma and discrimination program in KPLHS, and then the integration of the stigma and discrimination in the KPLHS. Since he used 30 minutes full scale of time, so we don't have time allowed at this moment for the question, but if you have question or need clarification, leave it on the chat box and I will come back to Mr. Thirdchai later on. So I think this is, I'm sorry about this, but I think we should move to the next speaker. If you need any kind of clarifications to understand the KPLHS model in Thailand and how it linkages to the hospitals, and then the stigma and discrimination reduction program in KPLHS, leave your comments, question in your chat box, please. So I think that the key point that Thirdchai mentioned on his lesson learned is really interesting for me too. Okay, I think we should move to the next speaker. So go back to you, Dr. Sin, to introduce the next speaker, please.
Thanks. Thanks to Mr. Thirdchai for his presentation and sharing, and also thanks to P. Niwa for summarizing. And also, yes, we don't have much time, and we will at the end of the section we might have a Q&A for a few minutes. So for the next speaker, I would like to invite Dr. Sunisa, Assistant Professor, Faculty of Nursing, Chulalongkorn University, and she also a member of Committee of Board Satisfying Training Program in Psychiatric and Mental Health Nursing, Thailand, and also a Nursing and Midwifery Counselor. So Dr. Sunisa, I would like to invite to provide your presentation.
Good morning, everybody. For sure, for my session, I just record my presentation, and I will share my video. And after that, if you have any question, you can discussion with me later. Okay.
Okay, Dr. Sunisa, thank you.
Hello, everyone. Today, I would like to share my experience of working to reduce stigma. Excuse me, let me ask about the volume. Is that okay? And discrimination in vulnerable populations. Can you hear my video?
Yes.
I think so.
Yeah.
It's too low?
No, it is okay.
It is okay.
Go ahead.
Yeah, that's okay.
Okay, thank you. Start. In another dimension this is an individual level work that connect to the community. This self-stigma reduction program work began with a view of the problem, though the HIV coexisting population, substance abuse and substance user, sex workers, and LGBTQ people, and foreign worker. So we have had problem with the missing appointment in healthcare service, lack of medication, and lack of good self-care, and even depression problem, and some increased drug use. When we analyze it more deeply, one of the main factors come from stigma and discrimination when entering society and when having to receive service in healthcare facility until his or her internal processes cause the process of stigma and self-stigma. And this self-stigma reduction program has been in operation for approximately 6 years, and aim of this program to help individual person to deal with negative thought about themselves related to their status, and negative thoughts such as guilty, blaming, and shame. The second aim is to gain the power to better cope with pain inside, as well as stigma and discrimination from outside to affect on their quality of life. For the program development, and cancel. From the program development, we begin with literature review to check about the conceptual framework that we will choose to explain our phenomena that we are interested in. And so we found the conceptual framework of Livingston and Boyd 2010, and we should to use that in our process of program development. And after that, we literature review for factors that related to self-stigma. And after that, we use expert panel and population focus to focus group to verify the information and let our information to more accurately. After that, the program was developed and bring to check the suitability back to the same population in the focus group. And after that, we use the academic and clinical expertise to help us to conduct the validity check. And we study with 2 quasi-experimental research to confirm our program that is effective or not. So detail will be discussed later. And next, I will show about the model that we use in our study. So this model from Bright and Livingston that I told you, the model describes an external situation that occur in the person, which is being stigmatized by society causing. And describe the internal process that take place from the experience of encountering stigma. The stigma was recognized and leading to more negative forecast. And we will find that our population will express about the guilty withdrawal or some isolation from the other. That is the outcome of self-stigma that we can find from our population. And from this model and process that I present to you, we conduct our program to work and to test with 5 modules. And the module one, from the module one, we enabling learning and understanding that stigma existing, and how does external stigma and internal stigma that self-stigma occur. And for module 2, learned and understanding the origin of negative automatic thoughts and understand that it is the cause of stigma, and learn that there is negative automatic thought. We can train to change that by searching for evidence to confirm the reasonableness of the idea. There is also a process of learning problem-solving skill, train them to have the good skill to solve for the problem that they found in everyday life of them. So for module 3, under self-stigma that cause negative self-feeling and feeling worthless, this activity in the module therefore focus on create positive thought on their self and surrounding. And for module 4 is learning to increase inner power by searching for his or her own resource to help their life or to improve their skill to solve for the problem. And module 5, activities for setting goals and moving forward to reduce self-stigma, leading to a better quality of life and proper health care. And for the totally of the 5 modules, so we intervene them with 15 hours for complete the program. So the 2 studies to determine the effective of the program are, the first one is the effective of self-stigma program in that use person and all people who living with HIV. Totally subject that is 50 cases in the control group for 25 cases, and experimental group 25 cases. And inclusion criteria for our population is IDU who use that for 5 years and more, and this study work in a center, I mean the health center in Bangkok. So, and totally case that complete my experimental is only 21, because we have 4 persons who drop out between intervention and between the follow-up process. So for the objective of this study that I told you, I need to compare self-stigma in person who complete my program and compare with the control group who have the usual care from the drop-in center. And the result I will present later. So the second study is the quasi experimental study, only one group, and the design of the study just only pre and post-test design. And the title of the study is the effect of self-stigma program in HIV and drug use person at the 3 hospitals in Thailand. The subject, the total subject were 74 patients who got the HIV, and I told you, and the inclusion that is they have the experience with this status 5 years or more. And the setting that is 3 hospitals, one is in the north of Thailand, Chiang Dao Hospital at Chiang Mai province. The second one is Nong Yai Hospital, that in the middle part of Thailand at Chonburi province. And the last one is Jana Hospital, that's in the south part of Thailand at Songkhla province. So the objective that is to compare self-stigma score before and after receive self-stigma reduction program. And for this study, we have the follow-up measurement. We follow up and record the data for until 6 months after complete the program. And let's see the measurement in this study. One of measure self-stigma by using question to identify how they feel about themselves at that moment by specify a score of self-stigma. The negative feeling that they feel. 0 mean not feel self-stigma, and 10 is feel so much self-stigma or so much negative feeling with their self. And the second clinical outcome, we record about continue follow-up and drug adherence, and I told you our population, some I use drug, and the consumption had measured in this study too. So let's see for the result. For the study 1 and study 2, as I told you, the statistical show significant for the difference of self-stigma score that I present to you later. And for the clinical outcome show decreased drug consumption and increased new case to the healthcare service, and motivate some case who drop out can be come back to get the treatment again. And for the follow-up, they continue follow-up, good continue follow-up, and drug adherence too is better. And more than that, some of our case present about the conflict. They change the a little bit. Some is not a little bit, is too big for their life, that they decrease the conflict with their partner or their family, and they got a good relationship with other person. That is very nice. And next, this is our work that I present to you maybe 6 years later. So the challenge for us to work move on, that how to continue of stimulation, and how to help them to create support group within the population, because they still on our healthcare service, they still follow up, and they still got the treatment, and they still got the activity that they work with the healthcare workers. So if we can conduct the support group, the good support group for them is really nice. So, and another challenge that is, I think our work still need to develop the program for feasibility in routine healthcare service, because as I told you, 5 module got 15 hours, and that is too long. So we challenge ourselves to develop our program again, that I present to you, Self-Stigma Series to be continued. So maybe we try to adjusting skill training and application of skill, such as turning negative automatic thought into practice at home instead of practice during activity, because we use too much time to training them, to practice them in our activity. That's why maybe some module take 3 hours for our activity. That is the challenge. So if we complete about our series 2, maybe later maybe in the future we can share our experience again. So that's it. And thank you for your attention. If you have any comment or any question, so you can ask. We will move on the live that in the room.
Welcome back, Dr. Sunisa. Real.
That is all my presentation and my experience that worked for 6 years, as that I told you in the earlier. Any question?
Thank you. Thank you, Dr. Sunisa. She left 10 minutes for us for questions or comments. So welcome all participants. If you have, after listening to her presentation, yes, a story about 6-year experience on working on self-stigma reduction. If you have any comments, please, or questions. We have 10 minutes around discussion. Are there any program in your country, in your own country, that dealing or related with self-stigma reduction? Are there? In Sri Lanka, in Tanzania, Pakistan, Laos, Cambodia, Mauritania, Timor-Leste? Are there? I see you move, Dr. Albert. Do you have any question? Yes, thank you.
Not a question. Rather, I thank the facilitator for taking us through the Self-Stigma program and sharing with us their experience. It was so interesting, and I think we have so many things that we have learned. In my country, there is no specific, as far as what I know, there is no specific intervention for safe stigma. Rather, it is equipped or in the large package of HIV reduction. So there is no single intervention for self-stigma. So it is something to learn for us. Thank you very much.
Thank you.
Thank you. Dr. Nessa, seems like today in Pakistan is quite cold. You have your jacket. You have anything?
No. I don't think.
Open your microphone first.
Yes, it is open. Can you hear me? Can you hear me?
Yeah.
Can you hear me?
Yes.
Yes.
Your voice is it is not to my knowledge that we
I
are running.
didn't hear you.
In
I'm not sure what's the problems.
Can you hear me now? Yes. Can you hear me?
Yes, Dr. Nisa, your voice is clear.
No.
Okay. I don't think there is any program running related to self-stigma in Pakistan, and it is not in
Hello,
my
Dr.
knowledge.
Anissa.
Yes.
Can
Can you hear me?
Yeah.
Yes. Maybe selected the channel on English channel first.
Yeah. Select the English channel. Okay.
And try again, please.
Okay. Can you hear me now?
Not yet. What's happened? I don't know. Okay. But I saw the other colleague from Pakistan as well. Miss Labie, you have anything? We still cannot hear anything from Dr. Anissa.
Can you hear me now?
Not yet.
Okay.
Oh, in French channel, we can hear you in French channel. Can you try again?
Can you hear me now?
Yes.
Yes, right now we
Okay.
hear you. Okay,
Okay.
sorry.
Okay.
Go ahead.
I'm
Yes,
sorry for
your
that.
voice is clear now.
I don't think there is any program running in Pakistan related to self-stigma at the moment. But for me, it is, I think 15 hours training is too much for the clients and for pre-test and then post-test. So I want to know the contents of the training regarding self-stigma so that we can develop a small questionnaire for our patients too.
Okay. Well, that is also the same that Dr. Sunisa mentioned in her lesson learned or challenges that maybe she need to kind of develop the shortened version. What about your thought, Dr. Sunisa, in order to apply to other country context?
Yes, it's my challenge. I mean, our team challenge to conduct the new one. I mean, the develop of this program to short version, and we'll try to pilot study in the process of pilot study. And I think maybe next year it can complete. And if we have chance to present, I will let you know. And another thing that I need to share about the measurement that I show in my study. If you see that is for me, I think for standard of the questionnaire, it should be more than one question. And as now we have one study to conduct our Thai self-stigma Thai version, and at this time it's nearly complete, and we will have the rating scale, the measurement as rating scale for 8 questions. And as now we try to check for the validity of reliability and validity of this instrument. And next year we will use this instrument more than maybe it might be good more than one question that we use in 2 study. That is my progression.
Well, okay, from one kind of academic background, she needs to make sure all things in standard. But anyway,
because let me say that because this I mean, for self-stigma reduction program, I think it's more than service, but I try to motivate my team healthcare team or my nurse team to develop the quality of care by R2R study to present in her hospital or to present in the public. That is why I strict for the measurement and the process to test for her care that they work to their population.
Yes. Okay. But in, well, that is Dr. Sunisa roles. But in the practical way, some of the nurses also, I think, a little bit applying for what she developed into their own context in many hospitals. So I'm so sorry that we don't have much time to bring you in detail. But I think from the discussion, it's mean like it's come up with lots of tools, right? The first one is how to assess whether our client or our customer in the hospital have their self-stigma, right? Or internalized stigma, assess them. And then what kind of tools that can apply into the context, maybe shortened one. And the last one that Dr. Sunisa mentioned is about the measure of the progress, how they recover, how they build up their self-esteem, how they understand their self-automatic negative thought and then recover from that. So I think that at least this might bring you some ideas of, if you're interested in about the key population-led services, the stigma and discrimination reduction in key population-led services and the self-stigma reduction program. We might come back later or about this, how can you learn more about this. So thank you, Dr. Sunisa. Stay tuned with us again, and then we'll maybe come back to you again later. So going back to, yes, thank you. Going back to Dr. Sin to a brief introduction to our last speaker for the Module 7, please.
Thank you, Dr. Sunisa, for her presentation and also Q&A response. And also thank you for Piniwa for facilitating. So this is the last session for module 7. So it's about crisis response system. The topic will be presented by Ms. Siriporn. So she is from the she's the public health technical officer, professional level from strategy and information technology section, Division of AIDS and STI, Department of Disease Control, Ministry of Public Health. So I would like to invite Ms. Siriporn, P. Siriporn, to take the floor for the presentation.
Good morning from Thailand. This is morning in Thailand, but I don't know in other countries. And let me share my presentation. Can you see my presentation? Okay, thank you. And good morning, everyone again. And thank you so much for giving me an opportunity to share my experience on development of the. There are many people that involved in the team, and today I'll share what we have learned and what we do when we develop the community-led crisis response system. But before we are going to the detail, just to briefly show you the big picture again. And I believe that you may have seen this framework like many times during the training, because this is as a blueprint for us to work in order to end stigma and discrimination. And I think that many experts, they already share their experience with you, that what they have worked around on the left side of the framework, that is to prevent stigma and discrimination. And however, there is another side of the framework that will fulfill this framework in order to end stigma and discrimination. That is what I will talking about today. The aim of the framework on the right-hand side is to protect the human rights and this is the crisis response system is developed for. And I just want to give you briefly on the background why we developed the crisis response system in Thailand. And the main objective that we developed, we want it to be a channel of receiving the complaints from those who are human rights violated. The human rights violation in this situation is related to age, gender, and also if they're being a member of a group that is vulnerable to discrimination. And the second objective is also we want the system to support the mechanism respond to the human rights violation, and want it to be our national database management system as well. So everybody can be used the same database in various organizations, and it will provide the evidence base for policymaker, for program decision, and also for improve our intervention as well. And this is the history of how we developed the crisis response system since the 2017. And we start at that year, and the first with the small working groups. The groups include the Foundation of AIDS Rights Thailand and the Division of AIDS and STI, which is under the Department of Disease Control. We talking about what we want the system to be and what is the key component if we want to make it success. And finally, we conclude that we need to have the team to work around the system, and also they need to have the tool on hand to work, and they also need the mechanism to support when they work in the ground or at other level of the right protection. So when we are constructing what we need, we start to develop the tool in 2018, and finally we got the CRS web application online platform in that year, and we also have the guidance, or we call handbook for right protection work. And when we got both two, we starting to recruit the volunteer as a team. We call our crisis response team to work in the pilot area. So that time we call out for a volunteer, and we got finally 8 organization of CSO or CBO in the area that willing to join us as a pioneer of the crisis response system team. So when we got that all in 2018, we start to train them in many ways. For example, we train for basic skill in stigma and discrimination, basic skill in human rights, and also we also train them to develop that skill in negotiation or other skill for human rights protection in that particular area. And also, I forgot, we also train them to use the CRS application as well. And along the way, we train them many times, and finally in 2019, we also engaged the partnership beyond the health sector and at the underlying ministry to join with us. So the team be more complete in that year. And finally, we officially launched the system, the crisis response system in the pilot area. The pilot area in this situation means the province that the aid organization located in. So we call that pilot area in our system. And after that, we got all, it's kind of, we got all component to move our system. So in 2020, we are full implemented the crisis response system in our country. But the response mechanism, as I mentioned earlier, only in the pilot area, 14 provinces. And we also promote the CRS among our key stakeholders and among key affected population. But the CRS, and its name, it's quite difficult to remember. So we promote the crisis response system with the other name we call Pokpong. Pokpong, it is a name in Thai word, and it means protect in English. So when we promote with this name, the people can remember easily than crisis response system. So this is just like a nickname of the system. And so when we promote the system in that year 2020, the case reported to the system increased. And our team, we call disciplinary teams, can work out like more in the real situation. And for this year, we plan to summarize the lesson learned and the model of CRS implementation in the pilot area. And also at the same time, we strengthening the provincial rights protection mechanism. And also we are going to do the data quality improvement in the system. And we do hope that we will get the model for expand the crisis response system right protection mechanism in another provinces across the country. And this just to briefly show you the name of the aid organization that is our pioneer in our project. And on the left side, it is they are the province that the NGO located in. And I want to emphasize again, since we work for 4 or 5 years, we recognize that the key component of CRS consists of three things. First, the heart of the system is the team. We need to have the people working in the system, whether either the crisis response team in the particular area, the technical support team, or the multidisciplinary teams that consists of many expertise agencies. So the second one, they need to have the tools to work when they go out, and we develop the guidance and also that data management system to help them to support them to work and collect the data at the same time. And also we need the law and regulation to support them to work smoothly. The last one, mechanism, we also needed to link every component together. And we are lucky that in Thailand we have the National AIDS Committee with the with the National Subcommittee on Human Rights Protection that this is the important body that will move the policy forward when we work, and we also have the referral network when we need help. Many organizations or many agencies they try to support us when we request, and these are all the key components of the crisis response system, or we call ปกป้อง in Thai language. And you can see that the data management system that we call ปกป้อง is just a piece of the whole system. So this is what all we have right now in our country in order to protect the human rights. And let me show you the video clip of the crisis response system or ปกป้อง that we used to promote in our country. Sorry that the video clip they're speaking in Thai language, but there are also the subtitle in English, so you can read through it. And if you cannot capture, if sometime it very fast, I will briefly summarize again after the video is in. So video.
สวัสดีเป็นยังไงบ้างให้ปกป้องช่วยไหมปกป้องคือระบบผู้ช่วยออนไลน์ที่ช่วยรับเรื่องร้องเรียนและคุ้มครองการละเมิดสิทธิด้านเอดส์เพศภาวะและความเป็นกลุ่มประชากรเปราะบางต่อการถูกเลือกปฏิบัติปกป้องทำงานบนพื้นฐานระบบ CRS Crisis Response System ซึ่งเป็นระบบการช่วยเหลือผู้ที่ถูกละเมิดสิทธิโดยทีมที่มีความเชี่ยวชาญจากหลายหน่วยงานพร้อมให้บริการครอบคลุมหลายกรณีถูกบังคับตรวจ HIV ถูกเปิดเผยสถานะการติดเชื้อ HIV ถูกกีดกันหรือเลือกปฏิบัติเนื่องมาจากการติดเชื้อ HIV ถูกกีดกันหรือเลือกปฏิบัติเนื่องมาจากเป็นกลุ่มเปราะบางกลุ่มเปราะบางก็จะมีกลุ่มหลากหลายทางเพศพนักงานบริการผู้ใช้สารเสพติดประชากรข้ามชาติผู้ถูกคุมขังกลุ่มชาติพันธุ์และชนเผ่ามาดูกันว่าเรื่องไม่สบายใจของคุณได้รับการจัดการอย่างเป็นระบบยังไงบ้างอันดับแรกเมื่อคุณเจอเหตุการณ์การละเมิดสิทธิจะกับตัวเองหรือคนรอบข้างและต้องการความช่วยเหลือคุณสามารถติดต่อปกป้องได้ทันทีเวลาไหนก็ได้จากสมาร์ทโฟนแท็บเล็ตหรือคอมพิวเตอร์แค่พิมพ์สวัสดีปกป้องผ่าน Google หรือ Search Engine อื่นๆคุณจะถูกพาเข้าไปที่ระบบบริการออนไลน์ของปกป้องที่ crs.ddc.moph.go.th หรือสแกนได้เลยเริ่มจากการบันทึกข้อมูลคุณสามารถใช้นามแฝงได้แจ้งแทนผู้เสียหายก็ได้และหากต้องการให้ช่วยแบบเร่งด่วนก็สามารถเลือกแจ้งเป็นกรณีเร่งด่วนได้แล้วยังแนบไฟล์หลักฐานเพิ่มเติมได้อีกด้วยบันทึกข้อมูลเสร็จตรวจสอบความถูกต้องอีกครั้งเสร็จแล้วคุณจะได้รับรหัสเพื่อใช้ติดตามเรื่องหรือเช็คสถานะในการดำเนินงานว่าถึงขั้นตอนไหนเพียงเท่านี้ปกป้องจะส่งต่อเรื่องของคุณเข้าสู่ระบบโดยทีมเจ้าหน้าที่จะได้รับการแจ้งเตือนทันทีเมื่อคุณกดส่งเรื่องและจะดำเนินงานต่ออย่างเป็นระบบจนเสร็จกระบวนการเริ่มจาก Screening คัดกรองข้อร้องเรียนเพื่อให้เจ้าหน้าที่ที่มีความเชี่ยวชาญแต่ละด้านมารับเรื่อง Investigation เจ้าหน้าที่ติดต่อกลับเพื่อขอรายละเอียดเพิ่มเติมให้ครบถ้วนและ Solution ดำเนินการช่วยเหลือตามแต่กรณี Report นำข้อมูลไปใช้ประโยชน์เพื่อให้เกิดการเปลี่ยนแปลงทั้งในระดับบุคคล องค์กรหรือนโยบายนอกจากนี้ปกป้องยังได้รวบรวมแหล่งความรู้เรื่องสิทธิและช่องทางการติดต่อหน่วยงานที่เกี่ยวข้องเพื่อความสะดวกในกรณีที่คุณต้องการติดต่อตรงกับแต่ละหน่วยงานเมื่อไหร่ที่คุณถูกละเมิดสิทธิหรือพบเห็นการละเมิดสิทธิด้านเอดส์เพศภาวะและความเป็นกลุ่มประชากรเปราะบางต่อการถูกเลือกปฏิบัติบอกปกป้องได้ตลอดเวลา
Okay, and this is the video presentation that give you briefly that how is the crisis response system or Pokpong work out when the complaints being reported to the system. And let me go back to summary again. Let me share the slide. And if you cannot capture the English subtitle, you can read through my presentation that I also give it to the organizer. And when this is just a snapshot of the system, when the event report to the system, the staff will know in real time via line application, this is the popular social media application in Thailand. Everybody have this application in their mobile. So when they know the events or the complaint come to the system, they screen and also investigate more additional information, and then go to resolve the problem, to providing assistance to the victim. And finally, we can use the data in the system in many ways. And this is if we need help, we can refer or request the help from many organizations. And these are our referral network. And just to show some data visualization dashboard in the system, when the data collection go through, and what we will see in the system in final. So this some of the dashboard that we can pick up the data to use, whether for decision making or for program improvement. And this also an example of the dashboard that we can see what happened in the system, how many complaints come through, and how many all cases, and whether the number, you can see the number of cases by type of rights violation, what happened more, and we can move our program to focus on that area. Just give you an example. And finally, the lesson learned from developing the crisis response system in Thailand, we found that most of the case report to the system come from the CBO or the CSO. So the CBO serve as an important entry point for the victim that they trust. So they tell them, the victim tell their community, tell their groups what happened to them, and we can bring the problem into the system more than we can overcome the limitation of a normal system that the marginalized population has limited access. And also the community is the key for response in this system. We should bring community, or we should bring the target population, target community in the system since the system start, either in development process, use of the system, and also to respond to help their community, and the co-development and implementation by CSO and government organization will be give us the optimization of the usefulness of the system. And this is all of my experience on working to develop the crisis response system in Thailand. Thank you so much. And if you have any question, please.
Thank you, Ms. Siriporn, for your presentations. We have 2 minutes left before we take a rest. If you have any questions, please. You may see that yes, okay, Miss Dr. Albert, yes, please.
Thank you very much, Mr. Niwat, and the facilitator. Thank you. First of all, thank you for providing us with a new vocabulary terminology of Thai, the so-called pokpong. So thank you very much. My concern or my question is, how do they protect the identity of the reporter, the so-called whistleblower? How do they protect them? Thank you very much.
Yes. So from this class, additional Thai words that you learn is about Khapun Klap and Pokpong, right? So this is the area that we jump. If you still remember the S&D framework in Thailand, that all of the contents are mentioned about promote the rights by reduction stigma and discrimination in health facility in other setting. But this area is jump across to the other line. It's about protect the rights that Ms. Siriporn mentioned. So we have 1 minute for one more questions or comments. If you have, it's okay. If you have questions or comments. So it's the quiet mean you're ready to take a rest. I'm so sorry to inform you that I will abuse your right, rather than give you 15 minutes for the rest, but I'll give you only 10 minutes. If you feel that you was abused, report it to Pokpong, type your case, and then Miss Siriporn will help you. Okay, thank you very much, Miss Siriporn, for your presentations, and we'll take a rest for 10 minutes and come back earlier because we have the last modules with lots of discussion. We'll allow time to discuss and share together. Thank you, Miss Siriporn, and everyone. Yes, please take 10 minutes less. Thank you. Welcome everyone back to the sessions. I assume that everyone's already in front of in the room, right? For those who already come back, give me a big thumb so I can, yes. Well, welcome back from Cambodia, Kosa. Yes, we'll start in 1 minute due to, wow, how can I say, emergence hit hard by COVID-19 in Bangkok areas and in many provinces. So some of our resource speakers that we invite them might be, need to do some kind of emergency tasks. So I'm not sure whether they will come back in time or not. But anyway, some of the speaker, most of the speaker or the resource person are already in the rooms. Okay, Sin Tuwins from Myanmar, how are you doing?
Hello, sir. I'm now quarantined.
I didn't hear your voice.
Hello.
Okay.
Hello, sir.
Seems like you are in uniform.
Can you hear me, sir?
On your work hours. So just try to test your microphone, all of you, because this session will be a discussion, sharing. So I'm not sure whether you're ready with your microphone or not. Sin, can you test it?
Hello, sir. Can you hear me?
No.
Hello, sir.
I don't know why today we have problem with, we cannot listen all of you, some of you.
Hello, sir.
Can Gigi hear Sin Tuwin?
Hello, sir.
You can hear, right? But I can't.
Cannot.
Oh, cannot. Okay. So, so this is a ground rule. If you would like to speak, when you speak, but if we cannot hear you, I will send you a signal, and maybe you may need to switch and typing if you have question. Okay. I'm so sorry about that. We don't know why, but hope you เข้าใจ I can read your lips. you can say speak Thai, right? Okay, good. Okay, welcome back all of you into the module 9 session. Module 9 is intended to design to invite all of you to meet with the resource person from various experiences in order to help you to work through when you have a kind of initiation ideas or the idea to implement S&D program, reduction program in your country. And if you still have any kind of question or something that you need more clarification from Thailand experience, so we ready to serve you, all the resource persons right now. Dr. Sin, maybe I take this opportunity to read if this is okay, so I can go ahead, move ahead, since because we haven't.
I think it's fine, Piniwat, because I don't need to introduce the speaker in this section. Yeah.
Yes, thank you very much. Because of this session, we have lots of speakers. Okay, they already come. So I will invite all the speaker or resource persons who ready on your camera to open your camera and then wave your hand to say hello to our participants. You can see right now, Dr. Taweesap, welcome. I think that you may need to have to do a kind of urgent task. If you do remember, Dr. Taweesap we met him on the first day, right?
Good morning, everyone.
We still don't hear anything from Dr. Taweesap, maybe the microphone.
Can you hear me? Hello?
I'm sorry. I think we may need to fix Dr. Taweesap microphones. And Dr. Pachara from UNS, can you wave your hand, please? Yes, we didn't meet her yet, but today is an opportunity for us to meet her, Dr. Pachara from UNS. And Dr. Kriengkrai, wave your hand, please. Yes, two hands, both hands. Yeah, Dr. Kriengkrai is from Right-Head Chiang Mai University. You met him on the first day, second day on most measurements. Yes. And Kun Thananda from CDC, can you wave your hand, please? Yes, Kun Thananda from CDC. We didn't meet her yet, but today have an opportunity to meet her. So I think that's already, and the other 3 resource person or speaker from the previous section are still standby. Stay tuned with us if you have any kind of questions. So Dr. Taweesap, can you test your microphone, please?
Yes, can you hear me now? Can you?
Yes,
no.
yes, we can, Dr. Taweesap.
Oh, Dr. Kriengkrai can hear Dr. Taweesap, but I can't.
Oh,
Yes,
okay.
I can hear him. No problem.
Kriengkrai, can you hear me?
I select English channel. So
Yes,
it seems
yes.
like everyone hear him, but I can't. Okay.
Yeah, we hear Piniwa, and then we hear from Dr. Taweesap, Dr. Kriengkrai, and also I want to request all our speakers
So
to
sorry, I
select
can't hear.
Hello, hi, good afternoon, everyone. Can you hear me?
Yes, I hear you, Kim Thananda. Dr. Kriengkrai, can you test your microphone,
hello.
please?
Hello, can you hear me? Can you hear me?
Yes.
No?
Dr. Kriengkrai, I hear you. Piniwa.
Everyone hear me except
Yes.
Puniwa.
Sorry, I can't hear Dr. Kriengkrai. I choose the English word channels already.
Maybe Piniwa, you use off, on?
No.
No.
I'll check. Already check. I'm so sorry.
Kun Niwat, you can hear me ใช่ไหมคะ?
Yes, I can hear you. but I can't hear Dr.
Hey,
Taweesap
you
and
are
Dr. Kriengkrai.
so selective hearing.
Yes, I prefer female voice.
Selective hearing bias.
Yeah, so sorry. What about Dr. Pachara? Can you test your microphone, please?
Yes, Niwat, hello everyone. And I would like to also, I think Bedis also joined this section as well. You are...
I'm sorry, I can't hear. I don't know why. As a facilitator, so if I can't hear, it may be quite a difficult challenges. I hear Thananda, but I can't hear Dr. Taweesap, Dr. Kriengkrai, and Dr. Benjamin, Dr. Pachara.
Kuniwat,
So,
can we get
well,
G to explain? Can we get G to
yes, the other person can hear. So maybe can Kun Benjamin take the lead for this discussion, or Kun Palishat, because I can't hear until I find the way to solve this problem.
I think
select
we
the
are
English channel and mute original audio, but I can't hear.
P-Ban, what would you like to tell? I think Kuniwa, I think P-Ban is trying to tell something.
Can you hear me?
Yes, I do.
I think some of us.
Yes, I hear Dr. Sim, but I can't hear.
Kuniwat cannot hear me, right?
Yes, I think Piniwa cannot hear your voice. That's why he's continue talking.
Okay, I think G put in the chat box that we have to put select English channel. So everyone who has not select the English channel, please do so. So Kuniwat can hear. Kuniwat, can you hear me now?
Yes, I can hear you, Kun Ben.
I think some of us are in the wrong channel.
I see.
So
can you
okay,
hear
I
me?
hear Dr. Kriengkrai right now. Yes.
Okay. I select off, and now I switch to English now.
yes, please. Thank you. So everyone, please go to English channel. Select from your interpreter.
Niwat, can you hear me now?
Yes, right now I can hear you, Dr. Taweesap.
So you are in different channel.
Hi, Niwat, you are in English channel.
Yes, yes. Okay.
Ajahn is in French เหรอคะ
But anyway, seems like Dr. Taweesap have a nice view in the park. It's good for relaxing after, still work hard in serious situation in Thailand, in Bangkok. So welcome back. I'm so sorry. Apologies for technical problems. So I think we are ready now to move on to the next session. It's about the module 9 is we have invite at least formal 5-4 resource person to come and ready to answer your question, to help you, to assist you, or to guide you, even if you would like to draft your action plan for the next module that will be presented by tomorrow. So here we have Dr. Taweesap that ready for you to respond on the national implementation program, and then Dr. Kriengkrai on the surveys, and Ms. Thananda and Dr. Pachara on the resource mobilizations. That's for the beginnings. So I would like to start with from the participant side first, since we have 11 countries and you pass on already 6, including today, 6 sessions or 6 modules. You might have some kind of things or question that you need to ask directly to the resource persons. So if you have any questions, yes, please go ahead. For this, you can ask directly to all these speakers or resource person, or you can leave your question in the chat book. Please. Dr. Albert, you speaking? Turn on your microphone, please. Dr. Albert from Tanzania.
No.
No?
Yeah.
Okay, you don't have that at this moment. Yes. So any questions? Just like thinking about tomorrow, that you are planning to do your country action plan or some kind of program action plan. If you have anything related to the national program, the measurements, the resource mobilization, the implementations, you have a chance to ask the resource persons. Still waiting. So if I may start first to ask, I'm not sure whether from our resource person if they have anything or not, but I will start my question first. I think from survey from some program, action draft program that some of you sent in to our organizations. So I think maybe we'll start with the first question that is about operating our issue of concern, the issue of concern, whether it's challenges or barriers or opportunity for implementing a S&D reduction program at the national level or sub-national level. What kind of concern do we need to think about or plan? Even it's challenges, barriers, or an opportunities. So can I start with Dr. Taweesap?
Okay, so
for your guidance?
Yeah, so I would like to start first, and then maybe other person could share your own experiences as well as your own countries. I think the issue when we're talking about the stigma and discrimination, firstly, when we communicate or talk to each other, whether at the policy, at healthcare provider, or at people living with HIV, people may understand or perceive differently. So this is something that we have facing, and sometimes people may choose or would like to address by their own perspective. And when you have so many challenging issues, this is the thing that we have to find the common goal or common thing that to work together. From my experience in Thailand, you know, even we face stigma and discrimination for a long time, but the way that we starting rapidly, there are two things. One is the good story from outsider that can advocate or can have some good example that people inside our network could see this is something that we can work. The other is on the issue that when we see the other experiences, we might have to discuss internally what are the country or what not the country, what are the network or the people who working together would like to see in common. So this is something that is the learning and developing process during the last 10 years that we have. But once we are in the same or have the good common understanding and common goal, I think that would be the good start. And after that, when you have the good common understanding, we have to go step by step. As I mentioned in the beginning, when people have common understanding, we will have three building blocks. The first block is on the policy backup and action plan together. Second is on how we understand our situation in the same way, that is measurement. And lastly, when we understand how can we solve the problem, that we can measure it whether we are in progress. So if we are in this kind of step by step, I think the challenge or the obstacle would be something that is the thing that we could overcome. So I think I would like to start with this first, and then maybe other people could contribute. Thank you.
Thank you, Dr. Taweesap, from your point about finding common understanding and goal together. I think it's a good starting point. So from the other perspective that you work with various countries, whether Kun Thananda or Miss Dr. Pachara, do you have anything to add on the issue of concerns for implementing the national program or subnational program? I may start with, I saw already in my comment in my monitors, Miss Thananda from CDC, please.
Why me?
I saw you,
I think
Dr. Pachara.
you assigned me to talk about resource mobilization, right?
Yes, but maybe we need a kind of resource mobilization. Is it a concern of issue?
I think that basic thing for many other things that Dr. Taweesap mentioned. So may I speak from the resource mobilization point of view? And I think that link can link everything all together. First of all, nice to meet everyone. I think you're nearly the end of the course, which is very exciting to me and for us too, because it's kind of first virtual training during this situation. And I heard very good feedback from facilitators, and we also got some nice positive feedback from participants as well. So thank you for that. So today I like to share from the as a technical support team and also some funding support to by working with the Ministry of Public Health Thailand and also Laos as well for about the S&D program. And I was assigned to talk about the resource mobilization part. So I try to put everything together. To me, I think to get the resource, we need the good proposal to bring in every party together. So that's more like formalize the plan. And Dr. Taweesap mentioned we have to set the goals and strategy to go together. So I think that's more like the proposals. And I think the proposal, you will need the data, right? To show what the situation, what the issue, why we need to do the stigma and discrimination. So that will lead to the survey that Dr. Kriengkrai already shared with you how we get the data. So I think if you want to start your S&D program, you need to have your own data to show the funder or people who will give you resources to do the program. So maybe you can start with formalize the small part that can be very strong foundation for other thing else. I think at the strategy level, we can follow or reference the UNAIDS or global strategy. I think most countries who had been working on HIV/AIDS understand the issue about stigma and discrimination, which is the key barriers to achieving the 95-95-95 goal. So you get some advantage from the global strategy already, which you can reference on. So what you need is finding your country or your area based data. What if this really be a problem in your area? Maybe you can, if you are the national program, you can speak as a national level. But if you come from maybe hospital, that means health facility level or provincial level, you can just start from there. So I think we may have a variety of background that you can start with. So maybe you don't need to start from the national program. Maybe you can start from your facility program. So first, maybe get the data, use the measurement tools that you learn from the course that you Dr. Kriengkrai had shared. So the data, you can form this how much the magnitude of the problems, and you can form your local strategy or national strategy, whatever you are working with. It could be at the sites or the provincial level or at the national level, or it can be just a very small pilot program like Thailand started with just a few sites. And then I think the other things, before you get the resources, you may need to find your teamwork, or I think you are the champion that I could say who joined this training. You can be the leader of the S&D program in your country or your facilities or your province. So you are the first champion in your area or your country, but you need to bring more champions to help you. And for me, from what I see, if you are government, that's already good, because government is important to be the leader in the program. But the other important stakeholder could be your NGOs or community-based organization, and more importantly, the community people or the affected population that you want to serve or have the issue about stigma discrimination. So if you can bring at least these three people, leadership all together, so you can you have more heads to help forming your proposals and design the survey, so you can adapt the survey and use in your areas. So after you get at least the survey protocol, the intervention you already learned from this course that we have, like 3x4, we have self-stigma, we have crisis response. So we have a lot of tools in here. At least you can put it in the plan that if you find these problems, you will address, like if you want to address in the health facility, you might address by 3x4 interventions. In the community, you may adapt the self-stigma, or if you want to start with the human rights, you might use the CRS tools, the crisis response tool. So I think you can pick and choose which one is your priority or in the resources that you have. And I think if you have good data and good proposal, I think the money, some senior doctor here in the ministry used to say to me that money is everywhere. It depends on if you can get it or not, which at the beginning I quite not believe, but now I quite believe so, that actually there's some money out there or resources out there in terms of money. If you have good data and good proposal and good teamwork, you can find it easily. Not that easily, but you can find it. So I think the resources that you may be able to reach out to get support. I think globally, UNAIDS is the leader in campaigning the stigma and discrimination. So maybe UNAIDS can be one of the resources. And if your country has PEPFAR program, the US President Emergency Plan for AIDS Relief is one of their priority as well. Or Global Fund, I think at least 3 big organizations can be the resources, even though they also have the other implementing partners like local NGO or international NGO, like Clinton Foundation. I think many FHI 360, like the speaker in the morning, they also get it from PEPFAR. So you can look for the local or international NGO that are working in HIV area. So if you have good data and good proposal, you might be able to mobilize those for your program. What else? And the other things for Thailand, we also some area they can mobilize the fund from the local government as well, like we call the local government administration. If we can convince them with the data that this issue is important to the people in their administration, they probably be another resource that can provide this to you. Like if you have issue about the people using drugs, and if you can convince the authority who try to have the program to reduce the harm from the using drugs, stigma is one of the key barriers. You might be able to mobilize from there. So maybe I stop here for this round, just some thoughts that I put together from working with the Thai government here in Thailand and also in Laos program. I think that we have kind of good foundation to be able to mobilize. Thank you.
Thank you, Ms. Thananda. From what I capture here is you need two things before pick up money from other people's pockets. Money is everywhere, but in other people's pockets. You need human power, the major implementer and the other partners to work together. And the second one is you need data system. Two things, two components along with the process that Dr. Taweesap mentioned. So I would like to go a bit further to Dr. Pachara from UNAIDS, that if you have something that a person in each country need to be concerned of starting or strengthening their national program or subnational program, kindly if you can add some example because of additional example because of our colleagues, some of them are not from health perspective. They're working on they are from police department. So if you have some kind of additional things for concern, please, and Dr. Pachara, welcome. Please kindly introduce yourself first because we just first met. Okay, thank you.
Okay, I hope that you hear me clear enough now. And very delighted to have chance to see and also speak with you directly. I mean, I kind of in and out during the last 2 weeks in order to understand what the key point and what the question from the country. But it's very pleased that, I mean, we get a lot of good, good participants from various countries and have chance to, exchange with Thailand. Actually, Kunni was a specific question, but let's see how I framed it and will be useful for the participant. And also, most importantly, we really would like to hear from you because, during the course, we packaging, Thailand team packaging and put effort and try to explain what happened in Thailand. I totally believe that, not everything that can apply to your country. But in terms of what can apply and what you think that you can refine in order to appropriate and practical to your country is a critical. And also that's one. The second one, I know that, using the virtual, sometimes it's very hard to have the two-way communication. Based on what I observed from the question, when you interact with the resource person during the course, might be not really theory, as need. And also a lot of information give it to you. I believe that during this section might be good idea, good time as well. If you have really would like to deep dive, okay, I think this is okay, and this is what I really want to know. It might be another option before you go to the plan for the action plan for your country. Having said that, I think what I would like to say here, I'm thinking about main 3C, but after here many people, I add another 2, will be 5C. The first C is a commitment. I think in order to do the human rights and also stigma discrimination program, we really want to have the, political commitment, political will behind all of us. Otherwise, we cannot succeed. This is applied at the national level, provincial level, and even the hospital level is still relevant. I think Thailand, you see that a lot of the activity happen. It doesn't happen automatically. A lot of people team that you meet during the course, as well as leadership from Dr. Taweesap, make us to able to make it. Without Dr. Taweesap, without the high level of support, and commitment to make it possible, we unable to get to today. No, that's very critical. And linkage to what Dr. Kunantida from the TUC, Thananda said, from the commitment, we get into another level. Who can be your leader in specific area that can lead the way for us to make it possible? That we talk about a second C on champion. I think I strongly recommend from the commitment, get into the champion at the political level, at the hospital level, or at the what the topic level. I really pleased, and I mean, when we start discuss this thing in 2012, if you remember the flow chart, the first success that we get very good political support from the high level that Dr. Taweesap already mentioned. We get the champion like Dr. Kriengkrai to lead us the way on how to make the measurements practical and useful for the people. We have Kuniwat that become the champion and to develop the intervention and side by side with the community. And we have many more champion, Siriporn, Dr. from Chulalongkorn to champion on stigma, this self-stigma. We have e-learning, we have CRS, Pokpong. It happened because we have champion to translate the commitment to the action. The third C that I think really critical and become the guiding principle and really critical component that anywhere should have and have to give the space and even make them leading the effort is the community and also PLHV network. Without them, human rights and stigma discrimination effort cannot make it. I think Thailand is very good that we've faced with this issue for a long time. And we learn and PLHV network and CSO become the cornerstone to leading Thailand, get into the what should be and what can make the difference. You might hear from the many people mention that Thailand have the national structure which called the Subnational Committee on Human Rights Protection and Promotion. And everyone, both CBO and PLHV, are the core member of the committee and leading the way how to make it possible. That's very critical. Not just the PLHV alone, but everyone hold hand together. That's another subject. The fourth C, I'm thinking about coordination. Without coordination, we cannot make it happen. And coordination can apply various levels. And coordination always issue. Sometimes people do we always issue in terms of we cannot, if we would like to expand or if we would like to start a project, and without the good coordination, it's not going anywhere. And the last thing that I believe that you see a lot of the good initiative project in Thailand, but Thailand now in the process of expansion. Another C that I would like to be is we're going to make the impact when we have enough coverage. Thailand geared toward to expand and roll out the initiative to the national coverage, and then we will achieve the national target that we expect. At this moment, we achieve in the small site, in the pilot site, but not yet at the national level. This is a way forward. Let me stop here first, and then hope that we have time to jump in later on. Thank you, Kuniwat.
Thank you. We have 5C. I have another one. see is a challenges. But anyway, a challenges mean time. We have time limited, but it seems like this is a kind of conversation in our room, right? So the last the next question will be, you know, directly to Dr. Kriengkrai, but I changed in order to challenge him. I changed the question. I think that Dr. Kriengkrai already present some kind of things, lots of things. So I think it might help people a lot when they think about operating the survey system. So if they want to operate the survey system, whom do we need to work with? I think you are from academic point of view and you work with lots of partners. So whom do we need to work with and what kind of support that it need to be ready in places to operate the survey system and maximize the usage? So Dr. Kriengkrai, please.
Okay, thank you for the question. Before I address the specific question, just would like to add on to the earlier resource persons that measurements is one of the very important component. And I think it's if you haven't done anything about S&D, as Kun Thananda said, you will need some basic information to raise the funding. And another reason to do the measurement is that I think some of you might be quite overwhelmed with the content, with the vocabulary, something like that. And I think if you work with the measurements, it will make you more familiar with the concept, with the meaning and the terms that related to stigma and discrimination. And I think it's the advantage of the countries that start, and maybe some of the countries who participate in this workshop is about to start working on S&D. I think that one good thing is that in terms of the measurement is that for Thailand, maybe we started too early. And at that time, 7-8 years ago, there was no like a standardized recommended tools from the global. We have to like a mix thing from many places and come up with our tools. And good for many country that's going to start right now is that you will have a standardized recommended tools. For example, from the UNAIDS, we have official guidelines. So I recommend that in the operational point of view, start with those recommended tools. And of course, you can add some other basic variables and can add some questions that used in Thailand that we can share you. But that's one good thing that if the countries start now. To address the questions about who should be involved in the measurements, I think can apply from the Dr. Pachara answers about the stakeholders who work on the S&D as a broader view, because I think we can apply the same concept. We need to have the involvement from the policy makers, from the health administrative. If we would like to conduct a survey at the hospital's level, at least you have to engage and involve with the director of the hospital, something like that. And of course, the participants of the survey themselves, we have to clarify them about the purpose of the survey, because many times and some of the time there is miscommunication and misunderstanding, and they feel that we look for some mistakes, something like that. So to involve the participants themselves is very important. And also community people, and you may have to consult with the PLHAV group, something like that, before working on the measurement itself. So I think please, if you start to draft the plan, maybe at country level or regional level or at the local level, please add the component of the measurement. If you give you the basic information and have learned something more on this quite difficult topics, which is the S&D. So I would like to stop for now and maybe come back for another round. Thank you.
Okay, thank you. Since some country already said that they don't have the kind of evidence data, they have a kind of like qualitative surveys, but not yet the quantitative data. So might be start with Dr. Kriengkrai recommendation. So there's some mentioned in the chat box. Would like to hear something from Billis too. So today Billis from UNAIDS International also join us. So if you have something to mention in brief. Yes.
Thank you very
Welcome.
much. Can you hear me?
Billis.
Can you hear me? Hello, can you hear me?
Yes, Belis, go ahead.
Oh, great. Thank you very much. I'm sorry I'm not able to put my camera on. My internet connection is not very good.
I can't hear. Maybe, Billis, you need to go to the interpretation panels and then check the English.
So I check. Can you hear me now? Can you hear me now?
Yes, yes.
Okay, great. So I was gonna say that, and I already put it in the chat box. One thing that is really important.
Sorry, I can't hear you, Billis.
Okay, sorry. I don't know what's happening. Can you hear me now? Can you hear me?
Maybe I have a problem with only me.
Only
okay, so
I'm so sorry.
Okay.
Niwat, you choose
English.
Or might be better.
Okay, so like I was saying, I think it is important that countries focus on
asking maybe Billis, you can say, and then if you say already finished, Dr. Pachara can inform me, please. Go ahead. Sorry, I'll keep quiet.
Okay. So my colleague, Dr. Pachara, already mentioned the importance of working with communities of people living with HIV and key populations. I think it is, they have been at the forefront on human rights and gender interventions on stigma and discrimination. So it is really important that they are at the center of any interventions that are done in the country. But then another thing is, it is also important to also look at the guidance from UNAIDS on stigma and discrimination interventions that can be implemented at the country level. And I know that this training has a focus on healthcare settings, but it may also be good to see how stigma and discrimination in healthcare settings affect all the other settings, for instance, in the community, at the workplace, and even in the justice sector. So it's also good to draw not really a comparison, but it's also good to see how all these are interlinked and how they can be addressed at the same time. That's what I wanted to add. Thank you.
Yes, it's done. Niwat.
Okay, thank you. And in the last minute, I also need help, and then right now it's so sorry, I'm stuck and then feel a little bit shocked. So I hear that Dr. Albert also cannot hear too. So kindly again, there are instructions from our control room said that we need to choose the languages interpretations and then choose English languages and then mute the original audio. So this might help. Okay, so we have only like 10 minutes right now for this session. So it's really tough. I'm really lucky that I'm not in the high ranking levels. So because the tough is, if you are in the high ranking level, you need like to speak, you know, in a very brief minutes. So, so it's very challenges. So from this 10 minutes
Niwat,
yes.
I think maybe the country may have some questions, so that might be good to address their own. Yeah.
Thank you, Dr. Taweesap, to clear me down. So going back to countrysides, do you have any questions to ask to our resource persons? Will you?
Oh, it's so silent.
Yes.
Okay, Dr. Albert from Tanzania, please.
Yeah.
Thank you.
Thank you very much for this opportunity, and I really appreciate the inputs from the CDC, UNAIDS representative, and the last speaker. So I really thank them very much because they have given us directives and ABC on how to mobilize the resources on our proposed projects. So maybe on the key issues to develop the project plan, which is data, the proposal itself, and to have a team, of course, to involve with other stakeholders, that is well understood. And my concern is, can they or can someone give us a format of proposal? Because I know different agencies have different format they need. So if you can get a format or a proper way or components to be included in the proposal, it will be very good. Thank you very much.
Okay, thank you, Dr. Albert, for taking this question. So since we have limited of time, I'm not sure whether are there any questions from or concern from countries? Your last minute for the question. Do you have that? No? Okay, at this moment.
If there is no question,
Yes.
may I add something regarding to the political commitment and champion team. I think we always talking about commitment from the government or policy level. One thing that I would like to mention that when we talking about the government, the problem to convince the commitment to key issue is the thing that we, from my perspective, is that the government has to respect each other between government and key stakeholders and listening to each other. From in Thailand, we always have good communication and listening to each other. This is something that if we could establish the good communication and frequently talking together, that will building trust to working on some difficult issue. So my point is that when we would like to do things with different stakeholders, we have to be respect each other and listening to each other. And if the government don't have trust to someone or someone don't trust the government, that would be the difficult task So I think this is the issue that I would like to say regarding to the political commitment. This can apply to many things, even with the funding. That's why when we ask for funding, if people will give fund to others when they trust that this fund will give something better. So if you have good information, good data, and good intervention, so it's not difficult to get funding from anywhere else. So addressing to our question, so it depends on your context in your own country. You know, in Tanzania, I'm not sure where is the major source of funding, whether it's PEPFAR or it's Global Fund. So normally they would have their own format, and that but we can show the situation and then working with them how can we solve with this. Template or format is something that we have to follow the funder. No, it's not followed by our side, but it have to follow the funder. But if your government also has the fund, or the local government has fund, so talk to them. This is the problem of their own. It's not my problem. Is not the national program problem, is their own problem. So this is something, you know, in Thailand, even when we work with hospital, sometimes we don't have budget to provide them. But when they look at this is their own problem, they can use their own budget to do things without support. So I just want to make this example that might have some lesson to other when you have to apply this S&D intervention in your own country. Thank you.
Thank you, Dr. Taweesap. Well, the next person, maybe in the last minutes, if you have something to add on, I think I'll go to maybe Dr. Pachara first, please.
Thank you. I think what I would like to follow what Dr. Taweesap said, that and also assignment in the beginning on talking about resource mobilization. Would like to get back on the earlier discussion that this is a very right time in terms of for every country to advocate and put the human rights and stigma reduction, stigma discrimination reduction to not just a theory, but also translate into action. Why I say that? I mean, this year, everyone know that, I mean, just recently, we adopt the new political declaration, and with very clear target that state member adopt political declaration to achieve 10-10-10 target. And this 10-10-10 target is really backbone to support the ending AIDS in next 5 years or next 10 years. The second one that you can use as the rationale to mobilize the resource will be the global partnership to eliminate all forms of stigma discrimination, where Thailand as a one of member and Laos as a one of Laos and Nepal. I believe that the country who participate on this training can use this as the advocacy tool for you to make it more concrete action plan for your country, and one of them will be very critical setting will be the healthcare setting as the theme of this training. And another one, most of the on the UN side, this is also in line what the Secretary General, UN Secretary General talking about decade of action to promote the human rights issue. You can use these three things as the critical part to draw the funding from various donors. Having said that, I mean, on HIV-related stigma discrimination, it's very clear that UNAIDS will be the facilitator or support. I would like to encourage every country to get back to the UNAIDS country director and submit your proposal and propose your idea to them, and working with the national partner to mobilize the resource from PEPFAR or from Global Fund in order to implement. I mean, UNAIDS doesn't have big money. We can support, but we cannot have the implementation money for you, but we can help on the process. Why I mentioned that? Because the PEPFAR and also PEPFAR not yet, but the Global Fund as one of co-convener of the global partnership, and they have a commitment to ensure that the country have the resource in order to implement the project. That my last point will be, during last 5 years, global target said that countries should have 6% of national spending toward the neighbor intervention. But come to this year, after we pass 2020, I not think that we achieve this target. In Thailand, only 1%, less than 1% allocate to stigma discrimination intervention. I think all of us should working together to ensure that we have enough resource to make possible to work toward achieve the global goal. That's it. Thank you very much.
Thank you. Ms. Thananda, please.
Just short, maybe just to add on the question that Dr. Albert mentioned, the proposal. I think even though you don't have the fund to start with, but you can start the proposal using the data from other sources as well. For example, what I put in the chat is like many countries conducted the stigma index, which is another standard tool and conducted among affected populations like PLHIV. So you can start from there and use this as the background that you want to explore further. We know that the stigma happen and the big issue in the community and the facilities. So the tools that you learn from the course can be add on for assessing more in-depth situation in the facilities or the area that you are working with. So I think you may be able to find available data and reference that to start with. You can start small, but think you can put the plan in phasing or put in the proposal, like after you understand the situation, you will do this intervention, as I mentioned earlier. So that I think that could be very strong commitment and add to the Dr. Pachara points that many countries need to provide more budget on the stigma and discrimination issues. So I think if you have good proposal and team, so I think you can mobilize this, not too much difficult over. Thank you.
Thank you, Ms. Thananda. So the last resource persons, the last word to say the last words, Dr. Kriengkrai from Chiang Mai, please.
Just one quick issue and maybe sound quite very specific, but I would like the team to think through and decide from the beginning in terms of the measurement aspect of your work, which is you have to decide whether you will implement this as a research project or as a routine implementation, because the steps of work maybe need to be added for the ethical clearance, some other details along the way. So that's just one of my point to raise here. And finally, I will willing to help if any participants, any countries would like to have any help or technical assistance from Thailand on measurement, I would be happy to help. Thank you.
Thank you. Thank you. Can everybody give a big hand to our 4 resource persons? Thank you. Thank you. I'm sorry for limited of time, but for today, but for tomorrow, most of them, our resource person will come back again as a guest to listen to your action plan, and then they can provide more guidance or in details for you to get through your proposal or your action plan. So before we end up today, I think there are some announcements from Department of Division of AIDS. So thank you all of you again, and go back to Dr. Sin, please.
Thank you, Piniwa, and thank you for our facilitator and presenter for sharing their experience and also giving a lot of information for our distinguished participant. So we do have 2 important information to announce for tomorrow. The first is our team have already received full presentation. So from Pakistan, Dr. Nisa, and also from Sri Lanka, Dr. Vino and Dr. Albert, Tanzania, and our Thailand team. So for the presentation PowerPoint sample, our colleague have already sent on Saturday. So we would like to request to send at least 1 PowerPoint presentation to our team for tomorrow country presentation. So please send maybe today or tomorrow early. But I think it will be better if all our participants, as a 1 PowerPoint slide for 1 country presentation sent today. That will be better for our arrangement. So I would like to request to finish the PowerPoint presentation today and send to us. That is 1 request. Another one is about questionnaire. So we will send today the post-test. So I think all our participants will remember that we did have a pre-test. So we will send the post-test today to finish and also send back tomorrow. And also we have a questionnaire for course evaluation. We want to know whether you satisfy or what we need to improve in which area, and that. So we need your feedback, and also we need your suggestion for the next organized training. So these 2 questionnaires will be sent today, and also tomorrow. Please finish before the end of our section. So these are the 2 announcements we want to provide today. So I think that is from our side. So today, thank you for all your participation. So I would like to encourage again to finish the presentation and send to us, and also to finish the questionnaire. Thank you for your active participation for today. So we will meet you again tomorrow. Have a good day, and thank you. Thank you, Biniwa, and thank you our.
Thank you, and have a good day too.
Bye bye.
See you tomorrow. Bye bye.